Thanks to everybody for having me here. I know that we're going over time, but hopefully I'll have time to go through just a few slides. So these presentations were really interesting. And this is sort of a little different tech. This is not down to the molecular level per se, and it's actually a larger cohort of patients. So important about me is that not only am I boarded in pediatric rheumatology, but I'm also boarded in practice allergy, asthma, and immunology. And we've had a lot of collaborators, as have the prior speakers, and there we go. We have over 100 people that have participated in this research. I'm highlighting over on the top left, those that are particularly germane to today's comments. And of course, I have to give a shout out to my colleague, Betsy Mellons, who was on this project before I was, asked me to come in, and we have hopefully brought a lot to the table in trying to understand this. So on our initial publication, which was in 2019, we gathered cases of SJIA that had lung disease. We didn't specify whether treatment or when the lung disease occurred. And among those were children, of course, as part of the conversation today, that were on treatment with these inhibitors of IL-1 and IL-6. And as Alexi said earlier, there's been this ongoing question since the increase in lung disease has been correlated with the increased use of these biologics. Is there a role, and how does that bear on the lung disease that we're seeing? So our first series looked at the features that described it, the risk factors, and I organized that around the time that lung disease was there. I was actually quite hoping that there would be something akin to TNF inhibitors, and TB looks different. Is there an infection that's more difficult to find? And as you know, with all the caveats of a retrospective observational study, we didn't find any causality. We did note that there was a risk for pneumocystis, and I think that's well accepted, and we keep track of that, especially those children that are on steroids and meet the criteria for being on pneumocystis prophylaxis as a recommendation. There were features that are in the unusual clinical findings that were unexpected, and as an allergist, I really needed to look at coursing through common things are common, starting with infections, thinking about drug reactions, and of course, any of these three can come to bear. The next thing to look at was adverse drug responses. So adverse drug responses are a huge problem, as we all know. I think it's over $3 billion in the United States. It's a large proportion of hospitalizations. And if you look at this very simplified Venn diagram of really what are adverse drug reactions. So hypersensitivity are about a third of them. Rashes are about a third of them. These are all overlapping. And then there are organ specific, which is various kinds of directed damage or adverse responses by the drugs. And this, of course, includes drug-induced lung disease. And more and more, there are cases that come out that have pulmonary alveolar proteinosis as part of an adverse drug response. Those tend to be more now the rapamycin inhibitors, and those resolve after you withdraw the drug. We spoke very briefly at the beginning with some of the patient presentations, and what Rashmi was talking about was the immediate anaphylaxis to tocilizumab. Well, that happens within minutes to hours at the time of the administration. That's not causally linked, and that's not what we're talking about here. What we're looking at here is the idea of, is there a delayed T-cell mediated adverse drug response? And these are difficult. These have a latency of days to months after you initiate the drug. So looking at these, zeroing in. So now we have an unusual disease, a rare disease of SJIA. We have a very unusual pathology of pulmonary alveolar proteinosis. And now we're going into the rare severe delayed hypersensitivity reactions, and particularly the severe cutaneous adverse reactions, which are, about probably less than 1% of these. And these are the ones that are associated with fatality, and they're very dangerous. The one that was really brought to mind within the within the cohort of the children with SJIA that are developing lung disease is something that we all would recognize as confounded. It's rash, fever, and inflammation occurring in an illness with rash, fever, and inflammation. So how the heck do you even begin to tease this out? I draw your attention to this recent review in the Journal of American Academy of Dermatology. And I just want to point out that it is really recognized as quite difficult. And there's controversy about how do you even classify or diagnose a stress reaction. And further, this is more complicated in children. So looking a little more at how do you wrap your arms around actually looking at something that will have such confounders. So this is the Registry for Severe Cutaneous Adverse Responses. These Regiscar scores are for each of those scars individually. They've been put together by the dermatology world, and this one is particular for DRESS, drug reaction with eosinophilia and systemic symptoms. If you look down at the reference I have there, Sylvia Cardon sort of led the expert charge, much like we do with classifying MAS. This was a 7-year iterative process, and it resulted in this Regiscar for DRESS, which is widely accepted. DRESS publications in literature score as often as probable, certainly those that are definite. The features then are the rash that's consistent with DRESS, eosinophilia, peripheral eosinophilia, very confounded with SJIA, of course, is lymphadenopathy. Atypical lymphocytes, we typically have to have a manual differential. SJIA doesn't have organ involvement, so that should be able to be separable. And of course, these are children that are infection is looked for, and they are not ANA positive. The asterisk of the deep organ involvement is sort of the hunting order within DRESS, and particularly in children, and that's based on the Kim et al., which was 148 cases. Now, we don't have a denominator. So one of the parents said the child had eosinophilia, and my understanding was that was before there was IL-1 inhibition, and then it continued afterwards. So the absence of mention of eosinophilia and SJIA, and the absence of mention of rashes that are unusual for SJIA, in my mind doesn't mean the absence that these happen. I'd like to know that affirmatively. So I began looking at records of what was I thought was going to be typical SJIA to really supply that denominator. And when I did that, I was really surprised to find that there were a number of clinically diagnosed stress reactions implicating anti-IL-1 or IL-6 in children with SJIA, and these were dramatic. A number of them were ICU admissions. So then going from there, there are 56 cases that classified as drug hypersensitivity. I'll go into this a little bit more. And I also have a second series going that's completing enrollment. And within that, I wanted to find that denominator. So this is an international collection of institutional controls where I asked specifically, tell me about eosinophilia, and tell me about, did it occur during these drug inhibitors? I didn't ask whether it was at onset, because that was not really the question. I can tell you that I do know of several cases, that the one presented today is not the only one. But during drug inhibitor treatment, these features are not usual. So when you look at these rashes, none of us here would say that these are typical rashes for SJIA. And these are children that have lung disease or do not have lung disease. So a drug reaction can have different ways that it presents, and the latency periods can be different. So Serena Tam, who actually did some work with Gail Deutsch, she's now down at Stanford, looked at skin biopsy, and this is illustrates the features in one of these children that had a suspected drug reaction, and the biopsy helped solidify that diagnosis. So in A, that's a vacuolar interface dermatitis, and in the box B, there's perivascular infiltrate. So in A, you can see a dyskeratotic keratinocyte, which is felt to be one of the features that will distinguish DRESS, although there are no pathognomonic skin biopsy features. There are those that are consistent with, and then you can see the arrows in the smaller screen with B, those are showing the eosinophil. So all in all, this was a case that was diagnosed with DRESS. We asked Gail Deutsch to please go back on the lung biopsies that were available for these children that had sufficient information that they scored as having a delayed drug hypersensitivity reaction. And she did find eosinophils on every single one of the biopsies, with the exception of a few that were on high dose steroids. Now I happened with the detailed clinical information. I knew what the steroid dose was on the day of the biopsy, so I was able to supply that to her. So now when we go with peripheral eosinophilia, you can see in these cases with drug hypersensitivity, I mean, actually the denominator on the eosinophilia should only be 54, which means it's 93%, because there were 2 that just didn't have CBC results, which was a little unusual. But nonetheless, including those with the absence of data, you can see that the odds ratio of having eosinophilia, this is during inhibitor treatment. This is very different from not on inhibitor treatment or at onset before you have before you've been afforded any treatment. This is very specific looking at the drug, since I'm talking about possibility of drug hypersensitivity. Now, this is the same with this atypical non-evanescent rash that's extensive, typically is peritic. And one of the distinguishing features in DRESS, when you ask the dermatology experts on that, some of them say, I can walk in the room and I can look at the face and go, oh, that's DRESS. Well, 80% of those that reported rash reported features that reported that the face was involved. And then I did not ask that in the institutional controls, but you can see that on treatment, an atypical extensive rash was just not very prominent. Transaminitis, as we know, is very confounded in SJIA, and I did not ask the institutional controls to tease that out. What I'm including here in transaminitis are at a time when there was not MAS, so it was not confounded by active MAS, and that you had to have transaminitis that was twice the upper limit of normal in the clinical lab on at least 2 separate occasions. And this happened in 70% of the cases that scored as drug hypersensitivity. And again, this is with and without lung disease. And importantly, there were 3 that were characterized as drug-induced hepatic failure. One of those died before getting liver transplant. 1 was successfully transplanted and is alive. And the 3rd is a recent one who was critically transported. We recognize that this may be the biologics stopped those, gave the child steroids, and she remarkably completely recovered her liver function. Now, this eosinophilia is not minimal. The eosinophilia happened despite over 50% of these cases being on concurrent steroid treatment. The eosinophil is a very, very steroid sensitive cell, so this was unexpected. Absolute eosinophilia, our lab doesn't accept eosinophils over 200. There are those that don't accept over 400. Everybody includes that over 500 is eosinophilia. For DRESS scoring, you need over 700. If you look at the median and the interquartile range on these cases, you can see that this is dramatic eosinophilia. The highest in our cohort actually was over 13,000 for an absolute eosinophil count. Percent eosinophilia is similarly significant. So what this led to, and one of sort of the critical conversations I think for today, is that delayed hypersensitivity reactions can have a very strong HLA association. And that's what we looked for. So what we did was we had a convenience cohort of SJIA or adult onset Still's disease. There are some within this group. And we predetermined whether they had drug hypersensitivity reaction. Now, we intentionally included any case that had delayed, diffuse lung disease occurring in SJIA during treatment with these drugs. We intentionally included any of those cases that were found by looking in the records and finding that there was a drug hypersensitivity. And we also recruited any cases that we could find. In order to be part of this and in part of being the convenience cohort, is that you had to have either sequence data or DNA available so that we would be able to determine HLA. And we have colleagues in various centers that had that. Those that were involved with this will know that I went painstakingly and detailed through every case that didn't have lung disease to pre-decide whether they would meet a classification as a drug hypersensitivity reaction or whether they could be considered to be drug tolerant. There was one case that had eosinophilia that was during drug, not before and not after, had nothing else, and that was included as a suspected anakinra reaction. You may have noticed on my credits slide, slide number 2, that we did partner with our colleagues at UC San Diego, who have the Kawasaki Disease Research Center. And I'm not showing here, but I'm happy to take questions. We did the same analysis in a phase 1, phase 2A trial of anakinra in Kawasaki's disease, pre-classified, and found the same result that I'm going to show you. So we did find a striking enrichment for a class 2 HLA association. This is across ethnicities. Now, our cohort is heavily weighted to white European ancestry, and then other ancestries, of course, it's not just one ancestry, those are multiple ancestries. We do need to increase our numbers. And with drug hypersensitivity, like I said, this should not be those only with lung disease. This should across the spectrum, and in fact it does. So if you look, if the expected frequency is 20% across ethnicities for the DRB115 allele, you can see at a glance that these are remarkably enriched. And this kind of enrichment is what is found when you get an HLA association with a drug hypersensitivity. Unusual, you can see in the top left, was that we were unable to differentiate from any of the drugs that these children were on. There were IL-1 and the one IL-6 inhibitor. And this held true. You can look at the drug tolerant controls. There were 2 that had 1503, which is present about 20% of Black ethnicity. And I can tell you that this 1503 was present in those that clearly had the kind of adverse events we're talking about. 20 of those with lung disease also had biopsies, and every single one of those have the pathology that we're discussing. Now, when you look at this statistically, and the more kosher comparison are those that are one ancestry. And we were not in our cohort able to find any that were DRB11501, which is the one that's the European and white ancestry. So that odds ratio currently is infinite, which implies that there's 100% penetrance. When you lump them all together, which I know my colleague Mike Umbrella is here, he may weigh in on that, we're getting an odds ratio of 50 and these very significant p-values. Because of Mike Umbrella and colleagues, some very strong work in looking at HLA and disease association per se in SJIA, we know that HLA DRB115 is not one that is a risk associated for SJIA disease. And in fact, I know Mike is here. In his cohort where he has 773, we're talking very large numbers here, that HLA DRB115 is present in expected frequencies. That's in the 550 white ancestry, as well as the rest that make up that full cohort. Now, this was very interesting. So
Vivian, we're at time, so you have to wrap up quickly, please.
And I'll do that. So the cytokine storm and the drug hypersensitivity, we're talking about, do these 2 course along? So in the cases that had drug hypersensitivity, we have a 67% MAS happening during the course of exposure to these drugs. In my institutional controls that seem to not have drug hypersensitivity, that's a 3% rate during these drugs. So these drugs seem to be really quite effective unless you have this problem. Those p-values very high. There was, I think Randy Crone sort of sent this around, the cytokine storm article that came out in New England Journal of Medicine just this week. And one of the categories is iatrogenic, and it includes drugs, and you can see that this is gaining more attention, and it can be dress associated. So in conclusion, my key messages are that there is a drug hypersensitivity reaction that's implicating the IL-1 and IL-6 inhibitors. I'm not saying that you can't get PAP without this. I'm looking at this very particular cohort. We've identified it in SJIA and adult onset stills. There's a risk of diffuse lung disease, pulmonary vascular disease. I cannot overemphasize that it is really difficult to differentiate a drug reaction from the underlying condition, challenging and imperative. This finding of a very strong HLA association may help us sort out who is at risk. And then, does this happen in other illnesses? Well, there are already reports, and you can even see an adult COVID-19 related cytokine storm had a published report of delayed hypersensitivity in concert with these medications. So there is a lot of work to be done, but we find this to be an exciting result. And that's my last slide.